Good morning. We welcome our listeners as well as those watching us on our YouTube channel. My name is Tobias Mattei. I'm a deputy editor of the North American Spine Society Journal, and I have the pleasure to have here with me today Dr. Mads Hans-Peter Gay, who's the author of an article recently published in SJ entitled Computed Tomography Osteoabsorptiometry for Imaging of Degenerative this disease, and we'll be discussing the methodology and results of this paper today. Herr Professor, ein herzliches Willkommen und vielen Dank für Ihre Zeit heute.
Dankeschön. Hi.
Yeah. So will you give us a brief introduction of your practice, your academic affiliation, main fields of interest? I know you were at the University of Basel in the biomedicine department, but let us know a little bit about your research interest and how this article fits in your overall line of research.
Okay, so very gladly. So yes, I originally studied biomedical engineering as a mechanical engineer, and then did my PhD in developmental biology at the University of Zurich. And then from this standpoint, I moved to Basel, to the University Hospital, to the Department of Spinal Surgery, and did my first postdoc there for 4 years. And then 3 years ago, I moved to my second postdoc, which is here at the Institute of Anatomy at the University of Basel. And so during my first postdoc, my main focus was actually the regeneration of degenerative disc disease using a cell source, so nasal chondrocytes. And I published a paper on this, on the use of nasal chondrocytes to treat disc degeneration. And this publication, along with other work that we did, more or less moved into a ERC Synergia grant, which also incorporated a preclinical trial and a clinical trial phase 1 for the treatment of degenerative disc disease using nasal chondrocytes. And while I was working in this field, I always was a little bit disappointed with actually radiological methods used to more or less determine disc degeneration and regeneration, because what we see is most studies usually use MRI or also just standard X-rays, and they then look at disc height or also the black disc syndrome or these kind of things. But per se, this doesn't give us a readout of disc functionality. It gives a description of the disc, but not per se disc functionality. And especially when we look at regenerative methods, so for example, cell therapies, which has been used, MSCs and so forth, is that patients see improvement, however, not radiologically, or sometimes we see changes in the MRI pictures, but we don't see a change in pain symptoms, these kind of things. So when I then moved to the University of Basel in the Department of Anatomy, my boss, Professor Magdalena Müller-Gerbel, she had more or less developed or was part of the development of this CT osteoabsorptiometry. And she used this to more or less analyze different things in the past. And I then recognized the potential and said, maybe this would be possible to be used in disc degeneration. So to more or less determine the functional state of disc degeneration, and then possibly be used because, as I said, the University Hospital of Basel has this clinical phase 1 trial planned, that this could maybe be incorporated into this trial to more or less determine if regenerative potential can be seen using this method. So this has been more or less my past in the research field. Everything I did in my PhD has to do with developmental biology and nothing to do with spine research. Yes. So
perfect. And I just would like to put your research in context and highlight how relevant it is to our general practice in spine surgery. So the topic is, I'm very interested in this topic, and I think I share with you a narrative review that we ended up publishing more than 10 years ago. But the first time I think it was during my fellowship, I saw a patient with severe osteoporosis, and she had huge disc heights, and even the signal in the disc was very healthy with a very bright T2 signal. And I was impressed by that in some sense. I was not expecting, maybe to have normal discs, but those discs seem even healthier than for a young person. So we did some research in the literature, and we found that the relationship between osteoporosis and preserve anatomy of the disc, or inversely between normal increased bone density or increased subchondral end plate density and degenerative disc disease, was reasonably established in the literature. Some papers dating back to the 60s saying that patients with osteoporosis had increased disc heights. And then I remember in the paper we discussed some of the pathophysiological mechanisms for that. But I think, your study has to be understood in the context that we see a lot of patients with osteoporosis. There seems to be a clear correlation between osteoporosis and preserved disc height and delayed degeneration. And computed tomography osteoabsorptiometry seems to be a promising technique to evaluate that relationship. So one of the things that caught my attention, and I just want you to let us know, especially from us in the clinical field, we usually use DEXA scan as a method for evaluation of osteoporosis. So let us know a little bit more about what this modality of CT is. I understood from reading your paper that basically you're using a post-processing method of the CT scan and evaluating the house field units, and then just evaluating the surface of the end plate and compartmentalizing those house field units. But you may be able to give me a better description of the technique.
Of course. So if we look at DEX scan more or less measures the overall mineral density in the entire vertebrae. And a very critical factor actually in this method is also the partial volume factor. So how much of the volume of the total volume is pure bone. So in this sense, you get kind of a ratio. So when osteoporosis appears, that more or less you lose the partial bone volume because bone regresses. And we're with the CT OAM, we are really visualizing the end plate calcification, and this is different in the sense, so the partial volume ratio does not play an inherent role because we're actually looking at the cortical bone. And now, and what we're looking at is actually what we call the loading history of the joint. So I think it can be a little bit described as if you're walking in the sand, every time you walk on the same space with your footprint, you leave an indentation on the sand. And depending on how heavy you stepped on the sand, you'll have different depths of indentation in the sand. And you walk over the same area of sand 100 times. Then you have a historic kind of preservation of how your walking more or less is pressurized. And the same thing actually happens in joints. So if we look at the end plates or the subchondral bone plates, we see that depending on how load or stress is perceived on the load, that this leaves kind of a loading history. So, and this indentation in the sand is more or less the mineralization that is found in this subchondral bone plate. And this has been shown in different methods and also correlated with pressure, so invasive and destructive methods to actually determine how resistant are these subchondral bone areas, and has shown clear correlation in previous studies that this is the case. So how this process actually works is that we get the CT scans, and these CT scans can then be 3D reconstructed. We then just turn the vertebrae in a sense that we have a perpendicular view on the surface, the joint surface area. And then what we defined more or less as the subchondral bone thickness is about 3 millimeters. And then we more or less just look at these 3 millimeters and then say, show us where the densest mineralization part is in these 3 millimeters over the entire surface area. And this then correlates with the load and stress that is put onto this joint. And this is then more or less projected as a densitogram onto the surface of the joint area. I hope.
Yeah, so it seems, I mean, you're saying that there's a correlation. I mean, you're estimating the axial load or the historical pattern of axial load over that segment through the bone mineralization. And I remember when I was performing my initial research that it seemed also like it seemed almost like a vicious cycle, because it seems that the increase mineralization in the subchondral end plate, it's not only a surrogate marker of the axial load, but it also interferes with what we call the vascular pathway. We know that most of the disc is essentially avascularized, and most of the diffusion of nutrients, including glucose and oxygen, is mainly through diffusion. So this occurs through what is called in the literature vascular buds. And we as surgeons, sometimes we scrap the cartilaginous end plate, and you really see that punctuated pattern with those tiny vessels that go through that region. So I remember the literature clearly shows that if you have increased mineralization, you have a decrease in those vascular buds, and of course a decrease in the osmotic diffusion of the nutrients to the disc. So it's not only a surrogate marker of the axial load, but it seems to be a vicious cycle that ended up in this degeneration.
Exactly. Yes, and I agree with this point. I think one of the things that is, in a sense, most interesting is kind of the question, is it the chicken or the egg, which came first? Is more or less a failing of the mechanical properties of the disc leading to a calcification, and this then leads to inhibition of vessel nutrients, osmotic exchange? Or could it also be vice versa, that we first, in some sense, have a reduction of vascularization, maybe due to outer influences such as smoking and so forth, that then leads the disc to degenerate, and because the disc starts to degenerate, it loses its functional property, and through this then starts to calcify the end plates, which, as you say, is a vicious circle, so it starts to calcify. So I couldn't really answer the question in this sense. What is coming first is more or less the reduction of vascularization due to calcification the problem, or is calcification occurring because of a reduction of vascularization?
Mm-hmm. And one thing, so I mean, the topic is very interesting, but one thing I would like to now go through the methodology of your paper and see how it fits in this general framework of this field of research. So I understand you compare basically patients with degenerative disc disease and patients without degenerative disc disease. Is that correct?
Exactly. So there, I have to say, we so the degenerated discs, these are samples that we got, or radiological images that we got from the Department of Spinal Surgery here in Basel. And these patients had both MRI as well as CT scans done. And so this patient cohort is fairly small, just because CT is not a regular method used for radiological assessment of disc disease and with MRI. So we only had a small cohort here, and usually already a little bit progressed in age. The patients that we got, or the healthy patients in this sense, we had to, in a sense, blindly choose. So these are patients or radiological image that we got from forensic medicine. So here at the Institute for Forensic Medicine in Basel, all bodies that come in are first x-rayed by CT, and then afterwards they are gone through the forensic dissection. And so we then more or less looked at these CT images, and then to a certain degree could assess young patients where we didn't see any obvious degeneration by radiological images, and then use these as our healthy control group. This is, of course, suboptimal. However, if anybody, in a sense, can give me a set of radiological images of MRI and CT of healthy patients that have no pain, this would be great. But this is, the world doesn't work that way. We don't radiologically test healthy people. So that's what we had to work with. Yeah.
And one thing that I noticed that I think it may be a limitation that needs to be understood, and I don't get me wrong, but this by no means reduce the merits of your research and of the results. But I noticed that you didn't use, perhaps because of the low sample, but you didn't stratify patients in terms of the degree of this degeneration, or using, for example, the Freeman classification, which is routinely used. In the same way, I mean, the study didn't account for the modic changes that we know have a substantial impact upon the observed mineralization of the subchondrial end plates. So if you want to just expound on those.
Of course.
Then.
So we did actually do a classification of the Furman scale. We used the modified Furman scale, and there it was classification 3 to 6. So this is about the classic Furman scoring of about a 2 to like a 3.5, I should say, according to the old. But it was very hard just because, for example, in levels thoracic 12 to lumbar 1, we only had 5 samples and these kind of things. And then if we really went through all the different mineralization patterns for all the different degrees, this would have been actually just, it would have really reduced. First of all, it would have expanded the study extremely, because then we would have, all levels, so all 6 levels, and then Furman scales from 2 to, or from 3 to 6. And this would then just have split the entire thing, that we maybe only would have had 1 sample for 1 Furman scale, and then maybe in this. So yes, it is a drawback, and it is something that we would like to actually look at in future studies, possibly. And to the modic changes, so there we only had a handful of modic changes that we observed in the samples that we got and analyzed, because and they were spread out throughout the different levels that we were analyzing. So it would have been maybe 1 modic change per level, or maybe 2, and 1 didn't have any modic change. And there we have to say, because we excluded any herniations or also extreme disc bulging from our samples, just because we already said here the complete mechanical integrity is already lost. And we wanted to kind of see an early degeneration process, or one where pain comes up and not an observable functionality loss is yet seen. And so that's why we didn't then include the modic changes.
And that's very understandable. We know that it's very problematic to perform subgroup analysis with a study with a low sample, because as you mentioned, you may ended up with a handful or even 1 or 2 patients in each subgroup, and then any comparison becomes very anecdotic. So would you tell us what were the general findings of your studies, and what were the things that were maybe perhaps surprising to you, and what were the findings you would like to highlight to us?
So I guess per se, this is so most of the findings retrospectively make sense, but at the time, so one of the main things that we saw is that the calcification of the end plate that is cranially to the intervertebral disc has a higher calcification level than the end plate that is caudal to the disc. And this is, in a sense, surprising because one would expect that calcification would more or less increase the more load that we have on the body. However, when we take this into perspective, it actually, in retrospective, it seems clear. So that actually the intervertebral disc, through its special structure, takes actually the axial load, then transforms this into a radial load, and then actually into a tangential force that then more or less moves on to the annular fibrosis. And so also the other ligament structures of the spine more or less dampen the forces that come from one vertebrae onto the next. So, and this is often described as that actually the entire spine isn't multiple joints, but one continuous joint in a sense, because actually it's an entire level of dampening mechanisms. So what we really saw is that more or less the disc really dampens the axial load on the underlying vertebrae. And this then seems in a sense also to be the opposite than in level L5, S1. But this isn't in a sense so surprising because the sacrum is actually a fixed structure. And so it doesn't have the underlying dampening mechanisms as the overlaying vertebrae do. So there we see, first of all, a higher calcification in the superior end plate of the sacrum and a lower calcification in the inferior end plate of the L5 vertebrae. Additionally, we see a typical pattern, more or less, of the load-bearing system on healthy and then unhealthy disc. It changes completely, but in the healthy. And this does change throughout every vertebrae, but they do have a very similar pattern of actually the main calcification rim is really in the periphery of the discs, with local maximum points actually in the dorsal lateral periphery. And when we then look at S1, we actually see that this is totally changed in the superior end plate, that there is mainly actually the maximum load or the maximum mineralization is actually dorsally over the entire, so medial lateral distance, and then moves past the median, past the middle of the disc, and then dissipates a little bit more ventrally. And this we more or less lead back, first of all, due to the stiffness of the sacrum without having any dampening mechanisms underneath, so no intervertebral disc per se underneath that is dampening, and also due to the lordosis that we find in the sacrum. And this actually then also leads that if we look at the intervertebral disc of the L5 to S1 vertebra, it's actually more of a chyle than it is a disc in this sense. So it's more of a wedge than it is a disc. And so this will most likely also be one of the reasons for this change in pattern. Additionally, what we saw is, so this was in the healthy core cohort, and it was very, in this sense, predictable if we understand how the intervertebral disc works. So if you imagine the nucleus pulposus as a balloon and the annular fibrosis as rubber bands around this balloon, if I squeeze the balloon, the rubber bands will expand in axial distance. And actually, so then that through this so the annular fibrosis, more or less being connected to the end plates, more or less take up shear stress, and this leads to this increased mineralization. Now, when we look at degeneration, we know that the nucleus pulposus starts to lose water, also its integrity. And suddenly this axial force isn't being taken up by the nucleus pulposus anymore, but actually by the annular fibrosis, because more or less it's losing water, so the balloon is losing air. And through this, if we're now compressing, we're actually compressing the rubber bands and not making this axial load on the disc into this radial load and then tangential load onto the annular fibrosis. And this is also what we see in our pattern assay, so that we see that the annular fibrosis area, so this peripheral ring, thickens and extremely increases in mineralization density. And this pattern alters extremely from actually the healthy discs. And also when you look at the more lumbar region, so really L4, L5, more or less the entire end plate is completely calcified and no distinct pattern is really recognizable.
And the point that you mentioned that you saw a significant difference between the L5S1 segment and the more cranial segments in terms of the pattern, the spatial pattern of the mineralization. And you supposedly attribute that at least partially to the segmental lordosis at that level. It raises a very interesting idea for future study, which is to look at the patterns of mineralization and correlate them with spinal pelvic parameters, such as lumbar lordosis, pelvic incident, or sacral slope. So based on what you're describing, for example, it would be possible that patient with an increased sacral slope, or what we call those more horizontal sacrum, would have this phenomenon if it's really related to the increase of the lordosis at the L5S1 level. This discrepancy between the cranial and the caudal segments would be increased. Is that correct?
Exactly. So this would be actually a very interesting study, which I have to say we would not have come up with, but that's then where I'm not a clinician, so I don't know what is relevant in the clinics per se that I haven't worked with. So it would be a very interesting study, and it's definitely something that we're considering following up on with what the data we have, and maybe more data that we could acquire if we get more samples.
Perfect. And one thing that you mentioned that I also find interesting in terms of creating some hypotheses for future studies is that it makes sense when you mention that there's a constant axial load over the spine related to the weight of the body, and then at every level the disc work as a cushion and dissipates some of that axial load. So, and that's why, I mean, at least you told me that this is one possible explanation why the cranial end plate supposedly is under higher stress and therefore has higher mineralization. And one question that I have you observed, I mean, if that makes sense, or if that's the paradigm or the rationale for the findings, I would personally expect, for example, a higher degree of mineralization in the more cranial levels, because you still didn't have all those discs at the levels below to dampen the axial load, and a lower degree of mineralization as you go down. But I'm not sure if you were able to compare those or correlate with the degree of disc degeneration, which was also different at those levels. But
yeah, so I think it's a valid point, and so I need to also look actually at I have the publication here. So it's actually interesting that we see in this comparison, we see that it is actually lower in the more cranial region, so more thoracic area, and then increases in the more lumbar area. And I think there, one always has to think, I mean, the spine, we have the axial load of the spine, but what we shouldn't forget is what is also coming is actually the torque forces by the body of the segment of that spine. So more or less the stomach and what so forth, even in between a vertebrae, will lead to more weight on this area. And one thing we didn't analyze, and maybe in retrospect would have been also, is to also look at body mass index of the people that are being brought. So because if somebody does suffer from adiposis, or actually have a certain degree of more weight in the belly area, that this then could further increase actually the more dense mineralization of the lower end plates. But yeah, and I think this is then actually one of the things. So we see higher mineralization actually in the lumbar than in the cervical, the more cranial end plates.
So tell me a little bit about this method of analyzing CT data, because it's very interesting. But for example, in your study, in your paper, you mentioned that this may be a useful tool in the clinical practice for evaluation of progression of this degeneration. And I see as a clinician, I mean, the first thing, we don't evaluate progression. You get new MRIs when a patient has new symptoms, and chronic axial low back pain or worsening of back pain usually is not even a good indication for obtaining a new MRI, because there's little you can do for axial back pain in the absence of radiculopathy or neurogenic claudication. But my question to you is, do you see this being easily incorporated in the clinical practice? How is this post-processing method? Is it something that every hospital, maybe if you have a radiology with some training, they could easily perform that spatial analysis and provide some guidance on the degree of mineralization? Because that would be interesting. I can see at least getting that type of study, if it's available, of course, and becomes a routine in clinical practice for patients that you are thinking about fusing. I can tell you, we previously published a study on a classification called lumbar fusion outcome score, that we analyze factors factors which could predict a good outcome after fusion for chronic axial back pain. And we know fusion for chronic axial back pain is a very controversial topic, but there's a very small subset of patients that may benefit. And in our study, I mean, we evaluated degree of this degeneration, modic changes, and bone scintigraphy. So the bone scan uptake with technetium 99 at that level. And those patients that had our classification as 3, which is all those elements present, they had and they had refractory chronic back pain. They had a very reasonable outcome after a fusion. So I can see how, if I'm in that hard task of selecting those very few patients for whom I would indicate fusion for axial back pain, this may be a type of diagnostic study that I would definitely consider employing.
Exactly. So I'll first answer your second question and the first question. So it's actually a very easy method actually to use. So there's a software that we use, Analyze, that really you read in the DICOM data. One thing that is, and it's not time intensive, it's actually done pretty fast, but in the end it does take time, is to more or less choose you have to extract the bone that you want, and you do this on every slice. And I'm actually quite sure and quite certain that it would actually be easy to make a program that automatically does this, that one says, I want to have this vertebra, and then a mask is laid out, and then this is corrected for every following image. That one then has actually the vertebrae one wants, and then can change into the direction that one wants. And then afterwards, more or less choosing the end plate is also a very simple procedure, and then just saying, okay, give me the maximum output of the Hounsfield unit. So this is actually can all be automated with minimal work for whoever is doing it. And then in the end, it would be the work of the radiologist to more or less do a readout of this. So this would be very likely possible. At the moment, it's more manual than automatic. But I think if there was a high a need for it, or if people would like to try it, I think an automation would be fairly easily implemented. And in respect to studies and so forth, so as you said, I had in mind, and this is something that we're working on at the moment, is so less some of the patients that we had that had the disc degeneration, they then either got a spinal fusion or a prosthetic implant. And what we want to assess as a follow-up study is actually look at the adjacent levels and look at them pre-operation and then 1 year post-operation, and see, do we actually see a change in the patterns or also the calcium density in these adjacent IVD levels. Because this kind of goes into the direction, as you were saying, where is fusion necessary, where isn't it? And to see, because it's been reported, right, that fusion and lead to degeneration of neighboring discs. And it would be interesting to see, is it really a direct, more or less, cause from the fusion that these discs degenerate? Or is it possible, for example, that neighboring discs are already starting to degenerate or have a functional malfunction, I should say, and that through the fusion or the prosthetic implant, we're actually just promoting this to move along faster. So this would be just, in this sense, interesting to see if we have these spines that we're looking at neighboring levels, looking at them pre-operation and then post-operation, and then see what will happen if those that already show certain functional loss, if this gets worse after a fusion in the neighboring, or do they remain the same, or do healthy discs also then show function loss? And this would be an interesting study, because this would maybe then also help narrow down who do you want to fuse and who do you not want to fuse. Because if per se on the MRI you see only one disc is degenerated, the neighboring disc, they look fine on MRI, so we'll just fuse this disc. But if we then look at the functionality of the disc through the CTOM, then you might say, oh, okay, I see the neighboring disc is also starting to lose functionality. So if I fuse this disc, I'll probably promote a degeneration in this neighboring disc. And possibly also, it could be vice versa. That one says, oh, okay, they all look fine, so this is a perfect patient to fuse. And as I said, also one of the things that, or one of the main reasons that I did this was actually the regenerative medicine approach, just because all the regenerative medicine approaches or biological therapies, they always assess pain management, which of course is the most important. But it's always hard to say how much is placebo, how long lasting is it, because follow-ups usually aren't that long in these trials, is then to see possibly, do we also really have a functional recovery after a regenerative medicine approach, especially when we're looking at MSCs or other factors that are being more or less added to the disc. And there I can already say, so I've worked with a group in the Netherlands. They have been doing dog studies and then actually doing a regenerative medicine approach, and they provided me with the MRI and the CT data of these dogs, and I then actually did the CTOM of these dogs, and we can actually see that in some cases we actually see a recovery of the functionality. So we can clearly see, so they have enough controls and everything, that you have the healthy disc, you have the degenerative control, and then different controls for every treatment that they're doing. And we can actually show that we can recover some functionality with some treatments, even though this is also seen in a Furman scale, but it still has a validation that we actually have a quantitative measure in the sense of a functional output of this. So this was kind of the idea where I saw that this method could be used. But again, I only know from the regenerative medicine field what is needed, and I'm always open for any clinicians to get in contact with us and say, this method would be great to assess this or that, and talk about providing data that one could do a study on this.
And I definitely think, as you mentioned, that it's a very interesting marker to be used in basic science study for evaluation of any possible interventional method for this degeneration. But I can tell you as a clinician, if this is a study that can be easily incorporated to the daily clinical practice, either through an automated software or something like that, I can see the richness of the spatial information that it provides could directly impact our daily practice. I can say, for instance, I have a patient with a grade 1 spondylolisthesis and radiculopathy, and I'm planning to fuse that patient. And I could use an A leaf, an X leaf, or a T leaf, a PLEAF, or several types of interbody techniques. And if I have, for example, and we know that one of the major problems with an interbody fusion is, or one of the risks of the procedure that can lead to hardware failure later, is cage subsidence. And it's something that sometimes it's hard to predict, and even though not every subsiding needs an intervention, I had a few patients that they were doing great after a fusion, and then they had a minor trauma. They had an increasing back pain, and you get a CT scan, and lo and behold, your cage has some subsidence. And especially now that we've been using more expandable cages, there's some literature showing that the rates of subsidence for expandable cages may be even higher than for static cages. So I'm telling that because I can easily see a patient in a scenario where I'm planning a fusion for a patient, and I get a CT scan with this spatial map of the mineralization of the end plate, and it shows, for example, that the lateral third of the end plates, both the cranial and the caudal, are very mineralized. So probably in those cases, I would choose to get my cage exactly into that region to avoid subsidence, and probably would do a PLEAF. Or conversely, if that study shows me that the mineralization is mainly the central portion of the disc, and the periphery is less mineralized, I may choose, for example, a banana cage with a T-leaf and try to park the cage exactly in that region. So it's definitely a very interesting technique that once we see it bridging from the basic science realm to the clinical practice, it could have a direct impact upon the way we manage the patients and choose our surgical techniques.
No, definitely. So this is actually very interesting. Also, just in this regard, because we're at the moment also doing a study where we're actually looking at the microarchitecture of the entire vertebra. So where we did micro CT scans and are actually looking at dorsal-ventral in different layering to more or less determine what exactly is the microstructure of the entire vertebrae, and could this possibly have actually a role in the subsidence of cages. But we're only looking at healthy individuals where we got these micro CT scans from, and only on one kind of vertebra. And this might be interesting in one regard, because we're actually also combining the CTOAM with these micro CTs to more or less compare. And we hope to actually publish this year, which would maybe further also be of interest for that work. So
for sure. And a very simple study, for example, in the setting of spine fusion would be to analyze patients. We always get, for example, I always do my fusions with an O-arm spin and intraoperative CT scan for navigation. So we have a CT scan for every patient that I'm fusing. So I can see if I'm able to evaluate, to perform, use that data and ask the radiologist to perform an osteoabsorptiometry analysis of the preoperative CT. And then I may obtain another CT in like 6 months or a year, and then try to correlate those findings with, or try to analyze patients with and without subsidence and see if there's any difference in the data in terms of the bone mineralization, to see if that's a predictive factor for subsidence, or to unveil several other important parameters that may affect the long-term clinical outcomes. So I think CT scan, we always have, most surgeons tend to have a CT scan nowadays preoperatively for one reason or another, especially because this is the first study that even primary care physicians order for patients with back pain before the MRI. And if this can help us not only to predict our the technique we will use, but even the outcomes of the surgery, or as you mentioned, help us assist in the decision between fusing only one level or doing the fusion the other level, because it's already meaningfully degenerated, or in the case of the CT, there's a very increased mineralization which spans almost the whole end plate. Even though the MRI is not that remarkable for degeneration, it may be something that has a direct impact upon the clinical outcomes of our surgeries.
And this is something that I'm actually very happy to hear, because while doing this study and implementing this work, I couldn't imagine what kind of a scope it could actually take for clinicians. So I'm very happy that it has potential to work in different disciplines and that more studies can come out of this. So I can say for my part that anybody that has maybe data where he says, I have post-op CT data and I know if something failed or worked, we could get together, I could analyze this data, and this could possibly just more or less improve the field and help understand how things are going forward.
Perfect. And we'll provide your contact at the end of this podcast, and even the articles that we mentioned before, we'll provide a link to our listeners. Of course, you can find all Max informations as the corresponding author of the NASJ paper. But I thank you very much for your time. And this was a very interesting discussion. And congratulations again on your study. And we thank also our NASJ listeners and those watching us on YouTube for your time. And we look forward to see further research from your group on this very frontline research topic.